you very much. My name's Claire Turnbull. I work at the Institute for Cancer Research, and I'm a clinical geneticist as well. So this is a great opportunity. We've got a great panel, including the speakers earlier. So we have Amit, who you met before, so he's a haematologist, but also working in the Division of Genetics and Epidemiology at the ICR, researching genetic susceptibility with the focus on cancer and hemonc. Catherine Lewis from King's, focus on psychiatry. We also have Judith Hayward, who is a GP with a special interest in genetics, who also works in the Yorkshire Genetics Service with a particular focus on cancer, predisposition and neurofibromatosis. Imran Rafi, who's also a GP but working down south in Surrey, but has it also works at St George's University in medical education and has a role at the RCGP in clinical innovation in the Clinical Innovation and Research Centre. Claudia Langenberg is a doctor in public health medicine, but also a researcher at Queen Mary's University, focusing on the genomic basis of metabolic control. Nick Wald is also from Queen Mary's, previously the lead of the Wolfson Institute, and has held many posts in epidemiology and primary care, and currently has honorary professorships at UCL, St George's and Brown University in the USA. And then we met Arun Hingorani earlier, who is a practicing cardiologist, but also a researcher into cardiovascular medicine and the genomic basis thereof.
I guess the first thing to say is that certainly from the methods that are used at the moment, it will generate different AUCs or risk discrimination in terms of screening, but there isn't a huge amount of difference at a population level. The AUC might change a little bit. Of course, at a personal level it might be different, and that's a concern. But overall, fundamentally, it doesn't really change the fact that the discrimination is limited and modest, whatever method you use. And I would be very surprised if someone was able to develop a new method which is able to give remarkable discrimination due to all of the principles that you've heard today.
I think the common thread, what's the title of this meeting? Is there common ground?
Common ground.
Scientifically, I think the common ground is that polygenic risk scores in population screening are useful or near, is useless or near useless and should be abandoned. The difficulty is there's enormous, I think, political, financial move towards doing this with companies like Illumina, public-private deals. We've heard about the 5 million genome analysis. It's a technology that's looking for a purpose, not a technology that's answering an important question that affects illness and death. So my question is, what's the basis for those of you who think that it is worthwhile, thinking it's worthwhile?
What's clear is we've had 3 really excellent talks, great discussion in the audience, and all about communication and how we communicate PRS if it is implemented in the NHS and whose responsibility that is. We're talking about common complex disorders which are usually treated in primary care, but the challenge is going to be implementing education and training behind that to support the communication that we're going to have with patients, which are going to be quite difficult conversations.
My interest in primary care is not just around clinical genetics and cancer genetics, but around implementation in primary care, and I have a national role and remit around education and workforce development for primary care. So Imran and I are always thinking from the shop floor end. So in terms of, I think my first question would be, I think building on the point around cost effectiveness and economic analysis, this is absolutely key in a resource constrained healthcare system. My next question would be, who's going to do it? Would it be primary care? That's another question. I mean, at the moment in primary care, we have very little to do with the NHS breast screening programme at all. I think I would want to make a point around education and training. There is obviously a whole industry is maybe not the right word, but there's a whole industry and evidence base around risk communication. However, we do it a lot in primary care, and I think it's important not to overcomplicate. As Claire says, what information would we need to give somebody around a PRS score? In reality, maybe not very much. I think the other key things for me, and it was really brought out in all three talks, but particularly Amit's talk as well, is around the other risk factors as well. In the basis of a resource-constrained NHS and social system at the moment, we don't have enough smoking cessation support. We've got a weight management service which people aren't engaging with as much as possible. We have certainly where I work in a deprived area, people don't engage with cervical screening. They really very low levels. So that's another point I would want to make. In terms of education and training from a primary care point of view, again, it's something I would say often when we talk about educating primary care or educating anybody, people immediately think of, we need to put together an intervention such as a webinar, such as a program, such as a module. We know that in primary care, actually, people don't access information around genomics in a proactive way, in a just-in-case way. They don't say, I better spend a day learning about PRS in case it comes to me. They learn about it when the PRS pops up on their computer and the patient comes in and asks and says, what's this? And then we say, right, we need information at the point of care to be able to talk to patients about this. So thinking from an implementation point of view, actually delivery of education is delivery of information at the point of care. Informatics is key for this as well. So I could talk at length about this, but I think this is what I would, we are always thinking from the implementation perspective.
Modifying a useful screening test like mammography on the basis of PRS is not going to do anything worthwhile. In fact, it could make it worse, because if you do it sequentially, you'll lose cases. If you combine them into a single risk score, you might make a tiny bit better, but it's very, very small. And the cost of PRSs are easily going to be, even if they came down to £10 a go, won't be worthwhile for the marginal gains. So it's not a case for doing economic analyses and cost-effective analysis. It's to interpret correctly the information that's already available. Polygenic risk scores may have some utility, but I think it's for people to come up with what they are and for there to be a scientific consensus and say, yes, they're useful for that, but not for screening.
Three very quick points. One in response to Nick. I fully 200% agree with everything you've just said. I think one of the things that is often lost in just the kind of the best predictors being a consequence of the disease, some of that will emerge over the next few years as they're more dynamic. Large-scale blood biomarkers will be tested against polygenic risk scores and will be eminently obvious that they're better predictors against a static test that doesn't change since birth. So I think people will come to learn that, so that's a good thing. The second thing is, I think, as Arun has beautifully outlined, the evidence is pretty clear. And you were also very clear, it's specific, that example to cardiovascular disease and prediction. And so I think one of the things to consider is there are thousands of diagnoses, and there has been a lot of data opportunism where we've done the same genetic analysis of the same condition again and again and haven't actually learned that much more after a certain initial wave of success. So I think there is a degree of, a lack of proportionality. The effort that we invest into making something better that's pretty bad to start with for many of the conditions we've looked at, to considering of the many thousands of diagnoses, no one has genetically investigated, just because it's not so easy and because it hasn't been part of maybe a study that has done that for you and you can easily look at it. So I think my plea would be, consider all the other diagnoses where it might be useful, because they are currently not well predicted, but they're still common and they're still severe enough. So there's a large space of all diseases to be looked at, so we can't forecast. But then the point related to that, coming to possibly common positive ground, the best test, the cheapest way for getting a PRS across all these conditions, as you've said, will be a genome-wide array, will be dead cheap. If everybody in the NHS had that at some point, even if it was useless, for genetic prediction across the board of all diseases, we will learn something etiologically by having that information across diseases that haven't been studied to date. So I think there could be a positive, not that this is realistic at this stage, but there could be a positive outcome for something that it wasn't intended for, if you see what I mean.
Can I just go back to your example about mammography? So we know that from the UK age trial that screening women annually with mammography from the age of 40 does reduce breast cancer mortality. So if there's an economic argument to be made, and realise I'm changing the paradigm again, how do you think you'll make that case, and will it involve a clinical trial? And is there not a loss of clinical equipoise and an ethical issue about offering women with a certain genetic code screening whilst denying a large amount of the population no screening who we know will benefit?
And the second point was about communication. So we heard about the education of the workforce, but I think education of everyone is hugely important. Genetics is still standardly thought of as yes-no Mendelian type, and I think we have a huge amount of work to do, in the community to think of genetics as a continuous measure instead of a yes-no.
One is about the more widespread use of blood pressure lowering drugs and statins for prevention. I'm old enough to remember that when statins were first introduced for primary prevention, the 10-year risk threshold was a coronary heart disease 10-year risk of 30%, a CVD risk of 45%, because statins were patented and we didn't know their long-term safety. Over time, guidelines groups have reduced that threshold, now 10%, possibly falling lower, in the US 7.5%, which means that inevitably when you cross a certain age, you will cross that very low risk threshold. So what we're doing at the moment is we're treating about half the population over a certain age, and they benefit. The other half, in whom about the same number of events will occur, are not having the benefit. That seems to me to be an inequity that we need to solve. Genomic information has been very useful in helping us to understand the causes of disease, as Claudia mentioned, yet there are still many diseases that the NHS sees that we don't know the causes of, and we certainly don't have good treatments for. Most pharmaceutical companies predicate now their drug development programs on genetic target validation, often from either sequencing or GWAS studies. Now, the NHS and academia has a huge opportunity here to discover the causes of the diseases that our health system treats, and to use that information to make better drugs, to actually challenge the pharmaceutical industry to say, we have the data you need to make the right drugs for the right diseases. We'll share that with you, but we want some recognition for that. We want a revenue stream back into the health system. We want better access to medicines, and we'll challenge you to produce medicines for the diseases that we have the least effective therapies for first, not the diseases that are the most profitable. So I think there is a big genomic opportunity here. We haven't grasped it in the right way.
But I think the things that we all struggle with, it sounds like, or at least I do, is this dissonance that one experiences, the strap lines of I'm having a genetic test to prevent disease, which is very different to a lot of the discussions that we've had. I realise that a lot of the public discourse will be coarse, but then it puts an unrealistic expectation on a population programme, which is important, but then will the public not get upset when it doesn't deliver that in 10 years' time we've not prevented all cancer cases or heart disease cases?
We're in a resource-constrained system at the moment. It needs to be something that is going to make a real difference to outcomes and to management. I mean, for instance, this year in general practice, our contract is telling us that we're going to take the emphasis away from chronic disease and put it on access this year. So we need to think more widely from that point of view. And again, coming back to your point and the point of the gentleman in the audience, I'm sorry, I've got a better memory for faces than names, around what people's response is going to be to receiving this information, how they go, is Is it going to generate anxiety? Is it going to generate healthcare contacts that are perhaps unnecessary is a strong word, but aren't going to result in a prescription or a change in a health outcome? Is it actually going to disengage people from screening because they're going to be told they're at lower risk? So there's a whole gamut, which again, was highlighted in your BMJ article in Annika's introduction here, around how are people going to react to this information? Is it going to change their health behaviour? Is it going to change the outcomes? And actually, we do need to think more widely around the public health. What's there to back up other things which are going to affect health as well, along the lines of smoking cessation. So I'm just going to end with a bigger picture there.